make sure you've signed your permission slip for this lecture because there is a lot of pictures of penises. Unfortunately, they're not real, or fortunately, they're not real. So there's a lot of discussion. And again, you got a whole semester, a whole rotation of female GU. Now you get just 2 hours of male GU. Okay, so that might be too much for some of you. All right, so erectile dysfunction. So the first thing we're talking about, so we got 3-ish disorders here. So we're doing ED, which is erectile dysfunction, not emergency room or emergency department. All right, we're doing erectile dysfunction. We're doing prostate stuff coming up, which will be a big prostate, whether it be full of cancer or full of prostate tissue. All right, and then we'll end with testicular cancer. Okay, so erectile dysfunction. So this is a problem getting blood into the penis, or a problem getting blood out of the penis, or probably more getting blood in. You can take medications to get more blood in the penis, and then you have an erection lasts for more than 3 hours, and that's called a what? A priapism, and that's usually a problem with the drainage situation here. We're not draining blood back into the body because the way the penis works is blood goes in and blood should not go out if you want it to maintain erection, all right? So it's an anatomical marvel, I guess you would say, all right, that it goes up, and because of it going up, it actually kinks the vein right there, and it allows it to stay, as long as you're supplying blood to the penis, it's going to stay erect, all right? So we can have problems with the drainage situation right there on our big penis vein, or Snickers vein, right? So that's going to be and when the penis gets engorged, it's called tumescent, right? That's just swollen, and then it gets to an erect status once it has achieved a certain angle. I'm not sure what angle that is, but certain people have different angles. Like people with Peyronie's disease, they have a angle so much so that it's not capable of reproduction. But for the most part, once we have that angle, we have a lack of blood getting back into the body, and therefore we have an erection, right? So a swollen penis is called a tumescent penis. So tumescence is just a fancy word for swollen. Okay, and the reason why I bring that up is because we have tests we can do to assess for tumescence. All right, so it uses someone's like stamps. It's like, what do you use stamp? I just use tape, right? Anyways, there's stamps that you can use to see if the stamps separate. That means that the penis got big, and it got big overnight. Usually, our penis gets tumescent every morning around 4 to 6 a.m. Right, just from the surge of testosterone, and that's a normal response. So we can assess whether it's normal, like it's a problem with blood flow, right? If the blood flow doesn't happen, right? That means that there's a blood situation, right? They might have an inadequate arterial blood flow into the penis. And where do you have inadequate arterial blood flow at? What situation would that be? So ASCVD is a good one. What else? And diabetes is a really popular one. And then, of course, ASCVD, diabetes, and then these are usually the first things, or this is usually the first symptom of a failure of your microvascular system. Your penis vessels are like 1 to 2 millimeters big. So you can imagine, and the coronary vessels are also 1 to 2 millimeters big. The coronary vessels, the cerebral vessels are also very small. So if you have erectile dysfunction, you're at high risk. If you have a problem down there, you have a problem up there as well, right? In the heart and the brain. Okay, what else about this? So we have the vein up top right there, and that's important because you thought Lovenox was hard to address to patients. It's like, oh, take your Lovenox right here, avoid the belly button. Well, you have to tell your ED patients you give sub-Q injections in your penis, but make sure you avoid the 12 o'clock position. Otherwise, you can get a direct dose of your ED med into your bloodstream, right? So we can inject ED meds into the side here, right? I changed the color. All right, there we go. So at the 10 and 2 position, you can inject ED meds as if like sildenafil doesn't work or other ED PO meds don't work, right? So we'll talk about some of those treatments that you can do for ED. What else on this? So yeah, the corpus cavernosa, these are the spongy tissue. It's literally a sponge, and it fills up with blood based on the blood supply that's going in. Okay, so overview and causes of ED. All right, so what is erectile dysfunction technically? It's where you have a failure to maintain an ideal erection. All the spam people are calling me at 9 a.m. I don't know what's going on. Anyways, so we got, it's like 5 calls already. So I paid all my bills, I think. So anyways, failure to maintain an ideal erection for intercourse, all right? So it might be tumescent, but it's not erect, all right? So we have to have a ideal erection, and that's one that's ready for intercourse, all right? And this is also known as impotence, ED, erectile dysfunction, all right? It's a chronic condition. It can be a sign of diabetes, sign of ASCVD. There's an emotional psychiatric stigma. People don't want to get treated for it, and then they get a heart attack or they get a stroke. So it's important that we educate to this and that we encourage them to describe their symptoms if there's anything wrong, right? That should not be a normal finding. And it does increase with age, right? 80% of those, or you can say 70% of those over 70 are at high risk for erectile dysfunction, just with hardening of the vessels. ASCVD is a risk factor, and of course, with age you get more chronic diseases as well. All right. So anything that affects the vascular system, all right. So cardiovascular disease will be an important cause of erectile dysfunction. So smoking, all right, that's just hypertension and vasoconstriction in of itself. When you put the toxins in your body, they are going to vasoconstrict. And we want vasoconstriction or vasodilation for penises. We want vasodilation, right? We want arterial vasodilation. Okay, and also, so it decreases nitric oxide directly, and nitric oxide is what we want to vasodilate throughout the whole body, right? We have nitrates we give to patients with like coronary spasms, or nitrates for like CHF patients to reduce preload and afterload, right? They vasodilate or they venodilate, right? What are those meds called? Nitrates, but what are some examples?
PDE5 inhibitors?
No, that you take for blood pressure. What is it?
Like
We don't do brand names. Are you saying a brand name? Get out of here. No, it's Isordil, right? So isosorbide dinitrate, or you have hydralazine is one as well, right? So it promotes nitric oxide. They do it by different ways, but they're promoting nitric oxide from being released and into the smooth muscle, and that will then vasodilate, and that's what we like. But smoking directly inhibits that process. And yes, someone mentioned sildenafil. Sildenafil is going to promote nitric oxide to be released. It's going to prevent the breakdown of it essentially, and it's going to allow you to remain vasodilated, right? It was actually marketed and FDA was doing trials for it for patients with hypertension, right? And they gave it to them, and they said, you know what? I got an unusual side effect, right? I have an erection, right? So that's like, whoa, shoot. And then the guy in the room was like, I can sell this. I can make money, right? So that's how sildenafil came about. It was originally for patients with high blood pressure. Okay, it promoted all this nitric oxide to circulate, and of course let us have more erections. All right, so alcohol is a direct vasoconstrictor. All right, so patients that get drunk are usually unable to perform because of the alcohol. All right, it could also be because of the mental state, but also because of the direct vasoconstriction effects. All right, and then we talked about ASCVD and diabetes. Causes microangiopathy, so pathy of the microangios, so the small vessels get diseased, right? So in diabetes specifically, they get all rock candied. They get all glass-like and hardened, right? And that puts you at risk for ASCVD in of itself, but that's going to lead to hardened vessels that are crystallized, and they eventually get narrowed, and of course now you have erectile dysfunction, or coronary disease, or kidney disease, or high risk for stroke, right? So we can separate causes into cardiovascular, and then we have neuro problems, right? So you have nerve damage, you have nerves that are not working. Well, diabetes not only crystallizes that's a song, right? Crystallize? Anyways, it not only crystallizes the vessels, but it also crystallizes your nerves, right? And the nerves get neuropathy, so they're not able to perform, right? A stroke is going to cause direct damage to the motor sensors in the brain, but mostly the penis is a SNS, PNS, and it's okay now to say PNS faster, right? So PNS is the one that's used for the penis to get erect, right? So it's, the mnemonic is PNS is for the penis to get to point, right? So it's what makes it point, and then you need the SNS to fire, right, or to shoot, all right? So the actual ejaculation part is the SNS, right? So how does that happen? Well, it's reflexive. So it comes out of the spinal cord right here. So the SNS exits the spinal cord to the sacral area, PNS down here, and up here, I guess we say. And if you have a spinal cord injury or herniation or some problem there, you're going to have a problem with erections, right? And the penis touch sensors itself are, well, I guess you would say, you can see it's on a reflexive pattern. So that's why people in wheelchairs, people that are paraplegic can still procreate, because it is reflexive. But when you start having spinal cord injuries that in that specific area, then that's going to cause some issues, right? And we'll talk about prostate surgery and for like prostate cancer, or for a swollen or a big prostate, a benign prostatic hyperplasia, a patient with BPH. These patients need to ultimately get surgery to take out the prostate, and they can't delicately take it out. They have to take out the whole deal, right? And it causes nerve damage, and they will get erectile dysfunction. So it's an important conversation for them to have about what are their goals, right? If they're 70 years old, they're probably not. They have to figure out what their plan is. But we can also have we can get implants to help out with the situation. All right. Also under neuro would be psychologic stress, emotional stress, PTSD. So these things, these stressors are going to make it so that they cannot achieve an erection, because they're not only not in the mood for it, but they are too stressed to achieve an erection. All right. So these patients, like we said, we do tumescence tests to assess if the penis can get swollen. These patients with stress, yes, it can get swollen, but they have a neurological impasse, right? Just like you can blink right now. You can make yourself blink, right? But you blink automatically without thinking about it, right? So that's a normal, that's something that you can control. So the penis can blink, I guess you would say, right? It can get erect, but you can also control it being erect. Okay, so anatomic issues. So obesity can make it difficult for an erection, just with the weight of the patient, but also the anatomy can get occluded, and it's difficult to achieve an erection if it is hidden. All right, and this is not a Groveman description. This is an official diagnostic code. You can say someone has hidden penis. Right, so hidden penis is an official diagnosis. It's a problem. It needs to be addressed, and obviously weight loss would be recommended. But there's other things we can maybe do to help out. All right, Peyronie's is usually due to scar tissue, and the scar tissue contracts, just like we talked about with retinal detachments. If they have previous injury, the scar will like kind of contract and cause separation in the case of the eye, but here it causes the upward or downward curvature, so that the penis is unable to maintain an erection or be functional. Okay, and then we talked about the penis should get erect in the morning, and that's because of testosterone. So if you don't have testosterone, you're going to have a not erect penis or erectile dysfunction, right? So low testosterone can be an issue. If you have like hypogonadism, that would be more genetic, or if you're taking medications, but also ETOH directly inhibits testosterone, and of course muscle mass can affect testosterone, but also testosterone just decreases with age. So the most testosterone you ever have in your life will be in your mid-20s, and then it starts decreasing about 1% every year, right? All right, so substance abuse, which is about 25% of erectile dysfunction. So marijuana, opiates, cocaine, methamphetamines, these can impair the ability to get an erection, because you need parasympathetic to point, right? So if you have coke and meth that are all sympathetic, it can be difficult to point, right? They might be able to shoot, but not point, all right? And then med side effects. So the parasympathetic nervous system uses what neurotransmitter? Uses acetylcholine, right? So acetylcholine is if it's impaired, if it's blocked, you're not going to be able to achieve an erection, right? And then norepinephrine is needed for ejaculation. So a lot of these patients, they'll have retrograde ejaculations, or they won't be able to ejaculate. So that's an issue with patients that are on antidepressants that block norepinephrine, for instance. All right, and then serotonin. So serotonin itself is great for depression, not great for erectile dysfunction. Okay. And then GABA. GABA is always inhibitory. It inhibits tinnitus, inhibits vertigo, inhibits seizures, it inhibits pain, right? It also inhibits erections. Okay, so up here in the brain is where we kind of start the pathway. We have voluntary control, we have emotional control, and then all the way at the bottom, it has to leave the spinal cord to go to the penis to get it erect and to actually ejaculate, right? So we have psychogenic on the right here, psychogenic erectile dysfunction, where they have stressors, they have their not able to, they have anxiety, depression, right? They're not able to have the emotional state to have an erection, right? But these patients have normal swelling of the penis or tumescence, right? What else? And so the other part is if it's not psychogenic, that means there's a problem with testosterone, there's a problem with the nerves, there's a problem with the vascular system, right? So that's what we're looking at as far as the causes of erectile dysfunction. Any questions on how it works? Okay. So pathophys. So what happens in a normal erection? Again, we need the penis to get activated, the PNS and the penis. All right, they need to activate. All right, the SNS needs to get out of the way so we can have more brake versus accelerator, right? And it comes from the sacral erection center, or the sex center, right, is where your penis activity comes from. And that sacral area is where, and of course, if you have injury to that area, we can have potential causes of erectile dysfunction. But either way, we use acetylcholine, and acetylcholine is going to get released across these membranes, right? Across these neurotransmitter membranes over here. We got acetylcholine coming across these little nerve endings, right? Here's a nerve ending up here as well, right? On both sides, two ways to look at it. And those nerve endings are going to release acetylcholine, or they're going to eventually release nitric oxide, right? And what produced the nitric oxide? Well, officially it was the acetylcholine, but the nitric oxide gets made by different enzymes, right? And those enzymes are nitric oxide synthase. So it synthesizes nitric oxide out of stuff, right? And that's NOS, right? And so you need NOS, right? So that's like, Fast and Furious. I need NOS to get to go full speed, right? So it can come from nerves. There's nerve NOS. There's endothelial cells. There's cells that are surrounding the penis that can release NOS just into the cells, and that will then allow the vessels there to what? To vasodilate or vasoconstrict? To vasodilate. That's the whole point here. Is we want vasodilation, we want increased blood flow, right? So nitric oxide, how does it do that? How does it technically cause vasodilation? Yes, it just does, but we'll talk about the details because that's how the medications work. So you can understand how the medications also are ultimately either promoting more nitric oxide or production, or are they stopping the breakdown of nitric oxide, all right? So CGMP right here, this is our guy that nitric oxide is going to ultimately activate, right? There's a little middleman there, the guanylate cyclase, but either ways we get more CGMP. And CGMP in penis vessels causes them to vasodilate. And how do you vasodilate? Well, I'm going to talk about how you vasoconstrict. To vasoconstrict, if you push the doorbell, the dihydropyridine receptor, right, on a smooth muscle, whether it be a vessel or elsewhere, it's going to cause that vessel to, or that smooth muscle, or skeletal muscle, or yeah, skeletal muscle too a little bit, but smooth muscles mostly, it's going to cause, if you hit that little doorbell, it's going to squeeze calcium out into the muscle, it's going to bind to the actin, and it's going to, the tropomyocytes get displaced, it's going to contract, right? And the muscle contracts, that vasoconstricts. So how do we not make it contract? Well, we get rid of the calcium, right? That's how calcium channel blockers work. They stop it all the way up at the doorbell, right? But here we're stopping it kind of further inward in the inner workings. We are taking calcium off of the actin so that it can no longer contract, right? And we're putting calcium back into the storage area, which is your SR, your sarcoplasmic reticula. So we're displacing calcium, putting it back away so your muscle can stop contracting, right? So that's what CGMP does, is it vasodilates because it gets rid of calcium, right? It stops calcium entry, it puts calcium away. Any calcium that might be in a cell, it hides it, right? So that's the idea. And then we get, of course, vasodilation, right? And then with the vasodilation, blood enters the penis. So we go from a non-aroused state or a flaccid state to a swollen or tumescent state, right? Because those vessels dilated and blood fills that corpus cavernosa, okay? And then we break down the that CGMP. So that CGMP was great, right? That CGMP was there to vasodilate. And then we have to break it down, right? You can't have too much of a good thing, right? So you have to break it down, and it gets broken down by this enzyme here, phosphodiesterase 5, right? And why did I bring that up? Because you have phosphodiesterase 5 inhibitors. So if we do a PD5, phosphodiesterase 5 inhibitor, it's going to allow what? More CAMP to be around, or sorry, CGMP to be around, right? And CGMP is a good thing. It's going to promote nitric oxide, sorry, it's going to promote vasodilation, right? So that's what PDE5 inhibitors or your afils do, right? Your sildenafil, tadalafil, that's what they're all going to do, right? So that's how they work, right? So that's why we bring up these little details, all right? So again, how's this not going to work? How are you going to have disruption of this normal process? We got perfusion issues. We have problem producing nitric oxide. So like we said, smoking directly inhibits the production of nitric oxide. Okay, and of course, testosterone. Testosterone is also going to promote erectile tissue growth, right? It also makes more nitric oxide to be available to be produced, right? And of course, libido is part of testosterone. Testosterone also promotes libido, so that's part of the neurological components as well, or you could say psychogenic components. Okay, so to recap down here, so we have, just to see how this works, we have the sacral erection center sending the signal to erect, right? Releases acetylcholine right there, right? ACH, sort of, right? So releases acetylcholine, and then that's going to ultimately create nitric oxide, right? Nitric oxide is going to make its way into the cell. It's going to ultimately produce CGMP, right? So CGMP we want around because CGMP is going to cause vasodilation, right? So CGMP over here, if you follow it over this way, CGMP causes decreased calcium. CGMP causes decreased calcium, and decreased calcium means we have relaxation of those myosin light chains, right? You remember myosin, actin, Z lines, and all that fun stuff, right? So it's going to relax the smooth muscle, right? And we want CGMP. And CGMP gets broken down by PDE5, so we can give medications to stop that, right? Our PDE5 inhibitors will stop the breakdown of CGMP, so we have more availability of CGMP to vasodilate. Okay, all right. So that's the idea. Okay, for you to do Leviosa. All right. So symptoms and diagnostic tests. Right. So it's based on patient complaints. That's usually all you need. Right. You don't need to do like a fancy test and get a room of 10 people to observe. Oh, let me see. Okay, I guess you got it. All right, here's a prescription, right? So they fill out this little questionnaire here. It's validated, right? They did a survey and they said, oh, people say yes in the survey. They have likely erectile dysfunction, right? And you want a high score in the survey, right? Almost always able to achieve to finish sexual intercourse, right? So they want a high score on this. They have a low score. It's highlighted down here. It's not showing up, but a high score is great. A low score means you have erectile dysfunction. Okay, so the other way to assess this is loss of morning wood, right? And we can't say morning wood in the textbooks and literature, so we have to call it tumescence. AM tumescence is poor, right? So you have poor AM tumescence. That means you have what? You have a neurological issue, a testosterone issue, a vascular issue, just anything but a psychiatric issue, right? Because if you have a psychiatric issue, I have ED because I can't get in the mood, right? So but then you do the AM tumescence and you have AM tumescence. That means everything's working organically, everything works, but it's just a you problem. So we have to find out a way to fix that, but if we give antipsychotics, that's going to, or antidepressants, that's going to make it more difficult, ironically, okay? But REM sleep and testosterone increases penis activity, or PNS, parasympathetic activity, and that's going to then allow the AM tumescence to occur. And again, back in the day, we had the stamps was the way to measure. We put stamps around the penis, and the stamp separated. Oh, you have tumescence. It's not an organic problem with your nerves or vessels, right? And then the other thing we can do is, or the other option we have now is a rigid scan, a deal you wear, just like you have a Holter monitor. You have to use this on your holster, all right, on your gun. Anyways, evaluate, all right? So for vascular issues, so A1C, what's an A1C going to look for?
Diabetes.
For diabetes, right? Lipid panel's going to look for
Cholesterol.
some ASCVD, right? They have high triglycerides, cholesterol, HDL, or LDLs, etc. Okay. We might do an ultrasound to see if there's actual flow in the penis. And then anatomic issues, they have Peyronie's disease. Do they have hypogonadism? Neurogenic, we talked about the stamps. And normal, if you have a normal tumescence, that's psychogenic. There's something psychiatric going on, right? If you don't have tumescence in the morning, then that is a problem with vasculature, a problem with nerves, or testosterone, okay? Something endocrine as well. So testosterone gets made, right? Where does testosterone get made? It gets made in the testes for a little bit, like 5% of it. The other 95% gets made in the adrenal glands, right? Specifically the first layer, right? So there's a little nougat center, right? And then there's 3 layers after that. The first layer is your testosterone that gets made. And then after that, it's cortisol, your glucocorticoids, and your last layer is your adrenal corticoids, or sorry, your mineralocorticoids, the ones that affect your minerals. Aldosterone affects sodium and potassium, one of your minerals, right? So those are your 3, that's kind of what your adrenal gland does real quick, all right? So that was pretty impressive, anybody saw that. Anyways, we got endocrine, all right? Could be an issue. We have decreased testosterone. It could be something wrong in the pituitary that's not releasing the gonadotropins. What tropin means, or tropic means, is to grow, right? So gonadotropins grow the gonads, so that you could have hypogonadism, or you could have a brain problem, right? And where do these gonadotropins come from in the brain? Where at? They come from the pituitary, right? The other ball sac in your body, right? So everybody has a ball sac. Only men have 2 ball sacs, all right? So that little pituitary sits inside the sella turcica, nice and protected, okay? So yeah, so testosterone has diurnal patterns, so it's as elevated in the morning, and that will cause tumescence to occur. You can see testosterone decreases with age. I thought I put it there. I might put it on a different slide, but about 1% every year. All right, so usually age 25 to 30, that's where we have the most testosterone, okay? And if your testosterone is poor, you can have erectile dysfunction, but also other signs. You can have fatigue, poor sleep, you have poor mood, right? Weight gain, that's not going to help, and risk of osteoporosis. So estrogen helps women to prevent osteoporosis. Testosterone helps men to avoid osteoporosis. That's why older individuals are at risk for osteoporosis, women because of estrogen, men because of testosterone. All right, so it has the same effect. All right, so what else? So we talked about these different things we can assess on the patient to determine if they have erectile dysfunction, but really just filling out this questionnaire on the low end is going to be a sign of ED. Okay, so non-pharmacological management. So what are some non-pharmacological things we can recommend? All right, so testosterone, we can boost testosterone production. That can be with supplements, so increase in zinc, right? There's supplements that don't work, like ashwagandha and vitamin D, right? So a horse herb is ashwagandha. That's not shown to improve it, even though it'll be on every 2 a.m. infomercial, right? But it's not going. I forget the name of it. But anyways, there's different things that are advertised, but really zinc is going to be the best thing to offer. Okay, it's not going to increase the size or length of the penis. It will allow the penis to get erect, right? So sleep is important. Sleep promotes testosterone. So those like bodybuilders are always getting like 9 hours of sleep, but they're at the gym at 4 a.m. It's like, what kind of social life do you have, right? But that's how they are able to grow more muscle, because they have more testosterone, because they get actual sleep. So 8 to 9 hours. It's like my testosterone is really low right now, so because of my sleep patterns. But either way, 8 to 9 hours is what you need. I meant you guys. I was talking to you, but anyways. Body fat percentage, right? So if your ideal is by 9 to 12%, nobody's that, but you can improve your fat intake, right? So if you're asking someone, or someone's asking you what to recommend, how would you decrease their fat intake? What would you say? Exercise will not really decrease your fat intake, but what's that? What? Eat good. All right, so good. Patient verbalized, I will eat good. All right. So what are some examples? How do you eat good? So saturated or unsaturated fats? So unsaturated fats would be a good start, right? Leaner meats versus thicker meats, right? So you want to make sure that we are recommending things that are going to improve their diet, right? And skeletal muscle mass will also increase more testosterone, because if you have more skeletal mass, you need more testosterone to maintain that, right? So we talked about the myths of like ashwagandha and such. So there's a big myth out there about soy. And soy, you have to eat an incredible amount, and even then, 1 pound of soy, I mean, have you ever eaten 1 pound of tofu? It's kind of hard, all right? 1 pound of tempeh, 1 pound of soy sauce, right? That's not going to, it's going to be hard to achieve. So, and it has no effect on testosterone levels. It's a complete myth, right? You would have to eat, you know, to like get your zinc intake though, which is important. You'd have to eat like oysters with every meal, right? So, excuse me. Some oysters right here, right? Yeah, so these oysters are not going to happen, right? That's hard to keep fresh, right? You have to refrigerate within 2 hours, I think, right? Anyways, that's not going to be great to achieve the proper zinc levels for testosterone. So that's why we recommend supplements in that case, right? So those are things to naturally do or non-pharmacologically do. These other things require some effort. Okay, so we have things that don't require a surgeon, which is a vacuum device. It is cumbersome to achieve this, to achieve an erection with this. Basically, they are trying to squeeze that vein, right? That vein right there. That's our goal, is to squeeze that vein. We could get the blood in there, or they might not be able to get the blood in there because they have poor vasculature. So what do? They just squeeze it in there, right? They vacuum it up, right? They vacuum it up with a device to apply pressure and to suck all the blood into the penis. And then you've seen the thing where the guy does his daughter's ponytail. You put the little and you put the headband over the top of it, right? So that the blood now is trapped inside, right? And now they're ready to go. They're ready for business. But it's extremely cold. It's like, whoo! Oh my gosh, that was what's going on. So it's like, it is a very cold experience. So that is a downside of this, right? It's of course you got to take it off within 3 to 4 hours. Otherwise, you're going to have a priapism. You've made a priapism. It's going to really hurt. And then they can just take the headband off, right? But hope it's not like a ring situation where you can't get the ring off. It's like, oh my gosh, right? Anyways. Okay, so yeah, so that is an option, right? The Swedish-made penis enlarger is an option, but the other option is to pump it up, right? Like the 90s again, right? So those guys who have longing and nostalgia for the 90s, it's like, say no more. What I have right here is a device that we are going to, implant barbarically 2 little tubes into the shaft of the penis, and then we're going to put a little pump it up button down at the bottom. And where at the bottom? Not in the bottom, but in the testes, right? So they just like, excuse me, what are you doing? Right? So you pump it up and it's ready to go. Okay? So here's an example of the pump it up action. Let's see, where is it? There we go. So here's a pump it up, right? It's a little squeeze, squeeze, squeeze. Right?
That's wild.
It's going to be wild. When you're all done, you just press the release valve. I'm not sure if it makes noise, but that'd be pretty weird. All right, so treatment for ED. How do you fix it better pharmacologically? How do you pharmacologically fix erectile dysfunction? Because other things were non-pharmacological things we could do. All right, so we talked about how PDE5 works, right? And do we like PDE5 or not for erectile dysfunction at least? You don't. You want to inhibit it. You want PDE5 to not break down cGMP. cGMP was there to vasodilate. And our goal here is to vasodilate. So we want to vasodilate as long as possible, right? So that we can fill the blood into the penis, right? And that is what all these PDE5 inhibitors end with. They end with a fill, right? So sildenafil, vardenafil, Ivonafil, or Avant. Anyways, we got tadalafil as well. Okay, so what's the action? Again, it's preventing the breakdown of the chemical that is vasodilating, that chemical being cGMP, right? Doesn't affect size, doesn't affect duration, it just provides blood, right? And of course, you still have to have sexual stimulation for it to have effect, right? And what should you tell them not to do? not to promote more nitric oxide, right? Because this promotes nitric oxide, and it's going to vasodilate. I mean, should they check the blood pressure beforehand? Not really, but they should be not taking a nitrate and sildenafil or a PD5 inhibitor, because it's going to really overload nitric oxide in the system, causing a widespread vasodilation, which is life-threatening hypotension. It's not like, oh, your blood pressure might drop 10 points. It's going to drop like 50 points, right? It can cause them to die if they don't know that they have to avoid this other medication. So it's an important history to know, are you taking any erectile dysfunction drugs, right? Because we often in the field, and once gets called someone with chest pain, they give nitrates to vasodilate the coronaries, right? So we have to assess if they have a history of nitrates, right? So what else? So side effects due to vasodilation, just like with calcium channel blockers, you vasodilate in the brain, right? There's a rigid skull there, so that's going to cause increased pressure in the brain, so you get a headache, right? And then also you're vasodilating elsewhere, vasodilate in the nasal septum, and you're going to cause congestion, right? And then we vasodilate where else? In the GI tract, and makes their GI tract not want to work great, so they get nauseous. They don't want to really eat much, right? And it's really not explainable, but they get blue tinted vision, right? So historically, sildenafil or Viagra is blue, so you can associate it has blue colored vision, right? So again, down here, PD5 is what's increasing CGMP, or breaking it down. So you see this inhibits, PD5 inhibits CGMP, and we want CGMP to achieve an erection, right? So we bring in sildenafil to stop that from happening. Okay, so also the more life-threatening side effect besides life-threatening hypotension is priapism, right? So an erection lasting more than 3 to 4 hours, right? So when that happens, we have to figure out how to get the blood out of the penis, right? So it can happen because of sildenafil or their Swedish-made devices, or it can happen because of SCD. What is SCD? Not like a centrifugal compression device. You put in the wrong limb at that point. Sickle cell disease, right? That's a life-threatening situation. It's limb-threatening, I guess you'd say, right? So everything's like life or limb is always the highest priority. This is a limb that can fall off, right? So we have to address that. So if someone has sickle cell disease, they can present with priapism, right? And at that point, they need what? They need exchange transfusions, right? Blood and hydroxyurea might fix it in a day or two. It's not going to fix it now, okay? And then ED meds we mentioned, and other meds like antidepressants can be associated with priapism, but non-ischemic is like a high flow state where you have trauma, right? Someone gets in a motor vehicle accident to their sexy center, right? Or their spine, right? The T5 to L2, et cetera, right? That can cause tumescence, right? So that's a sign of spinal cord injury if they have tumescence. Like why are we having tumescence after a motor vehicle accident, right? Those things don't go together, I don't think, right? But it's because of trauma. So it's something to be alert to that it could be a problem. Okay. And then how do we fix it? Well, you can try to wait it, do what best you can to wait it out. Maybe apply some cold compresses to reduce the swelling, or the flow of blood in there. But really, what we have to ultimately do is suck out the blood, but not in the fun way, the Swedish way. We have to core it, right? Just like you core an apple, you're going to get a serrated blade, or you get first of all, you start with a scalpel, just poke a couple holes in it, right? And you poke those couple holes in it, and you can allow it to bleed. Actually, sorry, there's a less vicious step before that. This is the last ditch effort, and that is definitely going to hurt. But it's also going to hurt when we put in a butterfly needle into the penis and we aspirate the blood. We just put a little butterfly needle there and you just pull out blood, right? There's a 7-minute video on YouTube where you can watch the whole process. Okay, so the commercial break will play it for you if you want. Anyways, we have cavernosal aspiration, and we, of course, aspirate it at 10 and 2. Why don't you do it at 12 o'clock? Because there is what? There's a big old vein right there, and there is a big old what? Nerve, right? There's a lot of nerves in this area right here, right? And a big vein as well. And we don't want to reduce, yes, we want to improve venous outflow, but that's not going to help. We want to reduce the spongy area that's filled with blood, right? And then what else can we do? So with what you would not aspirate at 6 o'clock underneath. Why? It's like, why is it yellow, right? You get urine, right? Also, it's awkward, right? So the doctor gets under the desk right there. Okay, no, I'm kidding. So that's going to be it's not easy, right? Most people are right-handed anyway, so it's easier just to put it on the side at 10 or 2. Okay, so that's the idea with pulling the blood out. And if that doesn't work, then we're going for all knives out, right? We're pulling out our scalpel, we're pulling out our coring devices to actually go through the glands of the penis, right? We're going to poke a hole in, and we're just going to suck the blood out with a syringe, right? And another feature of priapism is that the shaft is erect, but the glands, the tip of the penis is not, right? So the glands is deflated, right? It looks like a little mushroom, okay, or more mushroom-like. Okay, so we have our nerves, just to recap, right? Our nerves release, acetylcholine was involved over here as well, ultimately made nitric oxide, and nitric oxide is what's used to ultimately make cGMP, right? So cGMP is there to inhibit contraction of the muscle. It displaces calcium and stores calcium and puts calcium away, right? And then it allows the muscles to relax, right, and to vasodilate. So we have some other medications we can throw in there on the next slide to help vasodilate, right?
No matter how hard you try, no matter how ready she is, no matter how big your truck, and no matter who won that election, you just can't get it up. But there's hope on the horizon. Sildenafil. Originally, its intended use was for anginal chest pain, but came with an unwanted side effect, erections. It was then remarketed as the cute little blue pill we all know and love. Sildenafil acts by blocking phosphodiesterase 5. This is an enzyme that promotes the breakdown of cyclic GMP, which regulates blood flow to the penis. The end result? Filling drug companies' pockets much more than your own genes.
Common side effects include headaches, heartburn, or skin. Serious side effects include prolonged erection, vision problems, and hearing loss. Patients on nitrates, such as nitroglycerin, should not be on sildenafil, as it results in a serious drop in blood pressure. This is not a real thing.
All right, so sildenafil. So our next medications are going to work differently, but they're going to vasodilate ultimately, right? So we have this Muse system. It's cute, right? Because your Muse is what tells you good thoughts and good vibes, right? So a Muse, in this case, is called a medicated urethral system for erections. All right, so alprostadil is a prostaglandin, and like we mentioned, when we give prostaglandin eye drops, it burns. Well, this burns too. And you just got to rub it in, and hopefully it gets, the pain goes away. But then the woman's like, whoa, or the man's go, oh, all right, that's going to be a little burning sensation. So it's not very popular, but alprostadil is an option to put in there, and it's going to promote CAMP. All right, so what's cGMP versus CAMP? Well, in the vasculature, it does pretty much the same thing. It's just working on the other end. So cGMP was working on this end, nitric oxide is promoting more cGMP. On this end, CAMP is going to do the same thing. Okay, it's going to potentiate the vasodilation process in the vessels, right? So our side effects are burning. Why do they have hypotension? It's a vasodilator, right? And prostaglandin is an inflammatory mediator as well, right? When people have SIRS, they get hypotensive because of all the inflammatory mediators, right? And it's a teratogen as well, so that's not a good, it stings, and also it makes aliens. So that's not a great selling point as well, right? But if we need to, because it stings, that's also why you recommend barrier methods, right, for the man, right? So there's little applicators that can put the device in there, or the medication in there, and it works in about 30 to 60 minutes, right? And they can pee beforehand to really activate the medication. All right, so then that wasn't a great selling point, so now we have injections, right? So we give them little needles, and we, of course, teach needle safety, but also we have to know that they have to inject at 10 or 2 o'clock, right? And that's not the recommended way to drive anymore, right? Because of airbags and wrists breaking, right? So you want to be, how do you drive now? You hit autopilot, or you hit what? 4 and 8, right? You hit it at the bottom, right? Your arm should be at the bottom of the wheel. Cool. Anyways, so 10 and 2 o'clock for the penis still. There's no airbags. All right, so I guess there are technically. All right, anyways, we're going to stimulate prostaglandin receptors, which is going to increase CAMP. Prostadil is the same medication, but instead of being an injection into the urethra, now it's a not really sub-Q, it's intracavernosal injection. Okay, and Papa John's or Papaverin, this guy right here, right? He's not technically PDE5, he's a PD234 inhibitor. It's kind of the same. It's going to be the same thing though. It's just going to be more circuitous, more longer, PCH, highway kind of. I don't know. Anyways, it's going to be. It's ultimately going to increase CAMP, and that's going to vasodilate. Okay, these are all injections that can be given. And the last one is phentolamine, and phentolamine has other uses outside to avoid extravasation injuries. Like when patients get vasopressors that extravasate, it actually blocks all the alpha receptors, right? And stops those medications, those vasopressors from vasoconstricting and allows your tissue to actually recover. In this case, alpha receptors vasoconstrict, right? When you have the SNS activity, you have alpha 1 activity, that's going to vasoconstrict, right? So we give this one, which is an alpha 1 blocker. So now we have what? Yeah, vasodilation, right, is the ultimate goal there. All right, there's some other PO form. Yohimbine is a PO form that works centrally. But either way, these guys are blocking the SNS, right? And with these repeat injections, they can have repeat scarring, and that can lead to what disease? So Papa John's can lead to pepperoni disease, okay? So contraindications, okay? Anticoagulants, obviously they're going to start bleeding a lot more. Well, my erection's great. It's like, yeah, but now you have a hematoma, right? So that's not going to be fun. And then, of course, STDs with blood exposure. What kind of blood? Or what kind of blood-borne pathogens could they get? So Hep B, C, or A? B and C, right? So A and E affect the bowels, right? The bowels affect the bowels. Hep B, Hep C, HIV, etc., right? So yeah, so barrier method is also needed for these patients that are getting injections, right? So it's at 10 to 2 o'clock. Wear gloves, please. All right. What else? So that down there's just a summary table of how these work, right? So these are all the options for erectile dysfunction. So we'll take a break after this.